Good morning, everyone. And I would just like to thank everyone who show up early this morning on a rainy Saturday morning. I thank both Nick and Paul to chair this session. So, as what Paul mentioned, I will be telling you about the various work that my team has been working on over the last 20 months, together with many colleagues here in Singapore, and is to and how we uncover various interesting questions on the infection and immunity of SARS-CoV-2 infection. So I think many of you will know me and my earlier work at the Singapore Immunology Network, and just a little bit of history on Singapore's timeline against infectious diseases. So since 2003, I guess Singapore has sort of re-looked at the way we should be studying various infectious diseases after the SARS. And of course, we had episodes of avian H5N1 that although Singapore was not directly affected, but we were involved in various ways. And of course, we had the 2006-7 chikungunya outbreaks, which was at the time I started my research program as well. So right now, we are already almost the end of 2021. We are still living with COVID, and I hope that what I'll be sharing with you this morning and also later with from Antonio, it will give you various perspectives from the kind of work that we have been working on. So I was mentioning, I think many of you will know me from my Singapore immunology days, but over the last 1.5 years, as part of the transformation or rather reorganization that A*STAR has been embarking, they sort of rearrange or right-side various research teams in the various research entities, and as a result, there was the establishment of the A*STAR infectious diseases labs to look at preparedness. So in terms of the various pillars, the focus is going to be on vector-borne diseases, antimicrobial resistance, respiratory diseases, and how are we able to understand the various mechanisms of bacterial pathogenesis, viral pathogenesis, and of course, different questions on infection and immunity, and are we able to repurpose some of this knowledge, tools, and even platforms during pandemic situation. So in terms of COVID-19, as I mentioned, for the past 20 months, we have been working very closely together with our colleagues here in Singapore, mainly led by the NCID, together with NUS, Duke NUS, NUH, and also NTU to look at that falls under this umbrella, this study called PROTECT. So effectively, it is a multi-center study that aims to detect novel pathogens and also characterize emerging infections. So over at A*STAR, ID Labs, Singapore Immunology Network, and also together with Duke and NUS, NUHS, the aim is to look at, use various approaches to understand infection and immunity, and also specific the establishment of various assays, such as some serological assays or even other detection assays as listed here. So the use of multiplex cytokine profiling to understand some of the immune signatures. Also, we make use of high-dimensional immune phenotyping through flow or the CyTOF, and so on and so forth. Now, the questions that we were asking, not just clinically, is are we able to identify any underlying mechanisms of severe disease progression, because nothing was known in the early days. From there, are we able to identify biomarkers that was related to diagnosis or even prognosis of severe COVID-19? Any specific immunodominant neutralizing B-cell epitopes? We have heard from Professor Lin Fao Wang on Thursday, on his approach to establish the CPAS. So of course, what we had done was different, but it in a way complements the larger study. And that leads us to the point 4, the monitor of the antibody responses through some flow cytometry assay. So coming to one of the very common questions that everyone was asking in the early days and even until now was the involvement of cytokine storm upon SARS-CoV-2 infection. And what was the profile or the signatures like in some of these patients from mild disease to severe disease? Do they have the same profile, or are we able to look at them differently? So back then, with the first cohort of patients last year, in early last year when we had the first outbreak, so with NCID and the other hospitals, the clinicians were able to categorize the disease into three different categories. So mostly the mild patients, which we classify them as the mild without any pneumonia, and the more severe patients, pneumonia without hypoxia, and the more severe group of patients that needed oxygen, and even some of them ended up in ICU. So you could look at this two-way cluster analysis just based on the cytokines analysis. You will see that the pro-inflammatory signature actually get more pronounced in terms of the disease severity. So clearly essence of cytokine storm. And David already explained yes in his talk yesterday, and through all these efforts, the kind of the various therapeutic approaches that the clinicians had embarked on. So one of them was actually to target the IL-6. And from the same group of patients, we were following them last year, and this was the study where we looked at their profiles on 6 months. And right now, of course, the same group of patients, some of them are still with us in the 18 months study. But you could see here that what we've seen in the file, in the slides earlier, that during the early acute infection, of course, you have the very the high the intense signatures of the pro-inflammatory cytokines. But as the disease progresses into 1 month, 3 months, and even up to 6 months, you see that actually most of these inflammatory markers have subsided by then. But what was interesting is that when we reanalyzed these patients by a PCA analysis, just based on their severity at the early stage, you could see from here that even though they have already recovered, but they actually separate out quite nicely from those controls, people who were not infected. So I think this is something to look at as we are analyzing the 12 months and the 18 months group. So moving on, so another part that we were looking at was, okay, based on the cytokine responses, it then led us to look at what are the immune cell types that would be that have a very significant role in the early infection. So at that time, with the close collaboration with NCID and TTSH, we were, and also NPHL, we were able to get a cohort of the acute patients where we did a deep flow analysis just from their blood. And the intention was to look at the profiles of the specific immune subsets during the time when they are mostly viremic. And you could see from here, from the acute patients, you see a very clear differences in terms of the patterns compared to the healthy, and also the same group of patients who have recovered after 2 months. And what we found at that time was the increased expression of the CD169 and also the increased expression of the CD11B. And these are again signatures of pro-inflammation. And when we then proceeded with a heat map representation, we found that there is a high degree of markers that represent monocyte activation, as you could see from here. And also, I will say that it is not unexpected, but we were hoping to look at specifically at also the neutrophils population, and you could see very clearly that the acute patients also showed a significant upregulation of the neutrophil activation markers. Now, what happens after when we had a larger pool of patients that we collected? So you could see from here that by looking at the neutrophils population, we were able to actually discriminate between the acute patients with and also and how the profile looked like after they have recovered. And when we just zoom in into the specific immature neutrophil subset, which is actually represented by the CD16 low, high, and CD10 negative, you could see it's very significant. The difference is very clear. So the question was, would this be a useful prognostic marker in the early days? When the patient comes in, viremic, you get a small amount of blood and you run through the flow. And are we able to use this to be able to differentiate if if the patients would actually be severe or not? So this could be another form of approach to use that could help clinical management. So using the same approach, we then also recruited at the second part of last year, we were able to recruit another group of patients, what we call the asymptomatic patients, which were PCR positive, but actually had no symptoms, and this could be the people who were living close by or in the same household with the confirmed cases. So using the same approach to focus on the immature neutrophils, you could see from here that this is how the profile looks like. So the symptomatic, it's the group that we have seen earlier, and obviously, as expected, the asymptomatic group had actually lower cell count of the immature neutrophils. And when we went further to also then look at the other components of this asymptomatic cohort, we did a whole blood transcriptome, and you could see from here that there were actually lots of distinctive immune signatures that were generated. But once again, by looking at the two groups with the PCA analysis, they actually separate quite distinctively during the acute stage. So how do they look like if you go in depth? So this was the results obtained from the cytov panel, and also together with some of the cytokines panels, you could see very clearly that the patterns look very different from the symptomatic group, as we have explained earlier, and from the asymptomatic group. And it was interesting, you could see from here that the asymptomatic patients actually exhibit more robust virus-specific Th17 response. So I will leave it to Antonio in his next talk to actually show you a more in depth with on the T cell component of some of these COVID patients. So I'll just move on to another part, which is more related to antibody responses, as mentioned by Paul earlier. So this is just a little introduction, which I believe many of you are very familiar with how the SARS-CoV-2 structure looks like. It's a very huge coronavirus of more than 30 kilobase. But the various viral antigens that people have been really focusing on is pretty much on the spike, as we all know by now. You know, it's not just a very good detection target, but also vaccine target. But there's also the nucleocapsid that will be fairly interesting as well. Now, in terms of detection, I think we all know about PCR, but that alone is not enough. Right? We will need many other complementary methods, especially the serological methods that will enable us to actually complete the whole story between the asymptomatic patients or people who have been previously exposed before, but perhaps they never got detected in the earlier days. So specifically, I'll just home in to one of the particular assay that was established by Laurent Rainier and his team, which is a flow cytometry method called the S-flow, because effectively it is the generation of the S antigen in the lentiviral system that then enable a high throughput analysis of antibodies, specifically IgG or even IgM that is targeted against the spike. So with that, with this assay, it enabled multiple studies out there. So this, they have reported this late last year, where again, it's highly specific and also sensitive, and they could also follow, using this method, they could actually follow the patient's path for maybe to look at longitudinal COVID. And currently, this method was also used together with the various members, and some of them are in this room here, actually to really go a deep dive in the specific antibody responses from the vaccinated population here in Singapore. And this is just a little bit of introduction here, where most, in fact, all of the people who were vaccinated with the vaccine will actually will develop high levels of anti-IgG against the S. So I'll just finish off a little bit with with all the various assays that were then established, how they were used to monitor the vaccine status. And as we all know, a couple of months ago, then the vaccine breakthrough cases were reported. I think this was also due to the rise of the spread of the Delta variant, which I think we don't need to go into that. I think there are several talks that have explained that. So we then, the question was actually what happened to this vaccine breakthrough population. So this was done together with, I say, the other partners, specifically all the various commercial assays that were done by NPHL. You could see from here that, in fact, they do have high levels of antibody levels. And as I mentioned, Linfa already explained a little bit from the CPAS component the other day how the profile looks like. But I would just like to mention here that using the S-flow and how we compared with some of the other assays, you could see that yes, it's pretty complementary, but the question was on breakthrough, right? So we actually, what it shows here is that when we developed the S-flow against, by using the Delta variant, you could see from here that, in fact, the vaccine breakthrough cases actually did not have any inferior plasma antibody responses against the wild type and also the Delta. But when we went to look specifically into the frequency of the memory B cells, and this is where we found some clear differences. Now, which is our control group? Our control group is the close contact cases, like I said, people who were living in the same household, but yet did not actually develop the infection. And you could see from here that compared to the those people who had the vaccine breakthrough, they had a lower frequency of the RBD-specific memory B cells. So could this be one of the reason that led to the vaccine breakthrough? So I think there are a lot of other questions that are not known. Does age has an effect? I think we are still looking at that together with other members here. So I will just finish off a little bit where by looking at the cytokines again. I think this was always the question that Professor Liu Yixin has always been asking, by just using that, any difference. So we did the cytokines, and of those with the vaccine breakthrough, those with close contact, and these are the unvaccinated primary infection. These were the people who were infected last year, and we compared the analysis. Now, what you could see from here using the PCA analysis is that clearly the immune signatures of those who went through, who got infected naturally, they had a very different profile from the vaccinated. This is not unexpected. So I think this enables us some early clues to actually go deeper to understand some of the possible mechanisms of this. So I'll just finish off this last slide. It's we feel very fortunate that while we had to go through the difficult pandemic, but it also enabled actually many of the researchers to work very closely with the clinical community, and that enable us to learn about a brand new disease, even though the virus is pretty much, I mean, we know about coronaviruses, but this itself is a different monster. So I just like to mention that with all the various parts that we put together, it enabled us to contribute not just to the research, but some of these elements also facilitated. Okay. So, and it also enabled us to monitor the immune responses during vaccination, and how could we then use all these various platforms, networks to prepare better for the next outbreak. So I would just like to end off. I said it will not be possible without all the various contributors, close collaborations with the various organizations here. So with that, I'll thank you for your attention.
Thank you for a wonderful presentation, Lisa. I think we've got a few minutes where we can basically invite questions from the audience.
One in person.
And perhaps whilst people are gathering their thoughts, I mean, I can ask something. So, Lisa, in terms of these vaccine breakthrough cases that you guys have been analyzing, basically, at what point was the sort of vaccine response measured in these individuals prior to them manifesting infection? So, in other words, is there a time component in this?
Yes, I think that's a very, very good question. So the first collection of those vaccine breakthrough were upon the time that they were already confirmed PCR positive. And of course, that alone would not indicate when they were actually vaccinated, right? Because both of them would be vaccinated at different time. But so that the first point would be when they were positive, and then we followed them after 1 month, and also there was the subsequent 3 months as well. So there were different visits that we followed. So if your question is that point, the first point that we show was the time that they were sort of confirmed positive. And some of them were vaccinated earlier and some later.
Right.
But these were all, we only included those who've completed the full vaccination.
Who had a
there
full
were
vaccination.
many who
Okay.
who actually were in between, so we did not include that group.
But these were principally individuals that got infected between sort of 1 and 6 months after completing
yes. I mean, not that long. In fact, it was less than 6 months.
Okay, thank you. Okay, we have time for one last question. No? I think then, without further ado, I'm going to thank Lisa for a really wonderful and thought-provoking presentation this morning, and we'll move on to the next talk in this morning's session.
Okay, thank you.